two international experts, two well-known hepatopancreatobiliary surgeons on a very controversial topic. They are expert surgeons and also they are great organizers. Professor Sarablo is in the organization committee of the European African AHPABA meeting. And Professor Lang from the University of Mainz was the president of the 2017 Mainz meeting of EAHPBA. And now in the coming months, he will organize the third international expert meeting on cholangiocarcinoma. Today, we have a controversial topic. Even the title itself is somewhat controversial because I said vanishing, meaning becoming non-existent, but maybe we should have said disappearing, meaning they become invisible on imaging, but some of them actually are still there, or maybe it's a combination of both. There are no perfect answers, but there are, of course, individual institutional preferences. First, we will hear from the two experts, and then we will have, I'm sure, a lively discussion. We will start with Professor Sarablo of the University of Zaragoza. Professor Sarablo, please.
Hi. First of all, I would like to thank the HPB chapter, Turkey chapter, and Professor Özsin for this keen invitation and introduction, and the Professor Sokachu. It's very controversial point, and yes, well, in multimodal treatment area, the prognosis factor of colorectal liver mets have been progressively changed over the last decade, have been replaced by factor-intensive tumor biology and the interaction they have with systematic treatment respond to the preoperative chemotherapy. Specifically, the complete pathological response is the main prognosis factor, sometimes indirect prognosis factor, in the resected area of the liver metastases. The colorectal may present an indirect marker of tumor biology and his genetic. Van Belder and Coles usually said that each cycle of chemotherapy increased 18% the possibility to get disappear liver mets. I'm sorry. The optimal approach remains ill-defined. As mentioned, Professor Olsen, the balance with resected area or left in situ the disappear liver mets is real good approach or not. But to us, as a liver surgeon, the missing mets have a side effect. We are evaluated by our oncologist, our pathologist, and patient too, our patient too. The concepts is very different depending on what I want to mean. For example, radiological response. If the other hand, we have what is named the residual response, defined as when the metastases disappear after chemotherapy treatment during the follow-up. Therefore, this is the real name. When we speak about disappear liver mets, is radiological response. Under radiological test, the mets doesn't exist. Metabolic response. The metabolic response means that regardless of whether the lesion is seen or not in cross-sectional imaging study, it's not observable in depth, in PET. Pathological response, finally, we speak about this when in the biopsy or in the anatomical specimen after resection, there are no more viable cell tumor. That is to say, complete pathological response, independently if the CT scan or MRI appear or not. The complete pathological response has been questioned. Always, everybody thought that the cancer cell exists in the scar. But the first group to question or adapt this axiom was Paul Groups. In this study, René Adam and Coles analyzed 767 patients with colorectal underwent liver metastases after resection after preoperative chemotherapy. This studied the probability of complete pathological response based on 4 predictive factors: 60 years, age less 60 years, the tumor size less 3 centimeters, the CEA less 13, and objective radiological response. When the patient has 4 factors, the probability to get disappear liver mets was 30%. When with 3, around 10%. With 2, only 2.5%. And with 1, almost null. So, yes, there is possibility a complete pathological response. Furthermore, the authors realized the patient with complete pathological response also have better survival rate with statistical significance with compared with who patients didn't suffer pathological response. But once again, this is only in the 4% of patients. When we talk about missing, vanishing, or disappear metastases, we don't know if there is a complete pathological response or not. By this definition, mean in the fact radiological disappear of the metastasis after chemotherapy treatment. A new concept also emerged, namely the complete clinical response. This is the absence of local recurrency at the initial site when disappeared liver mets is left unresected. It's a new concept. The standard problem depending on its relationship with the diagnostic methods. It's very important to know which is the best in diagnosis of disappeared liver mets. This incidence of the missing metastasis has increased over the years, how Lucidi group showed us in 2016. It is increased with the improvement of the chemotherapy lines. You can see that there are several differences in radiological study protocols according to the author. Elias in 2004 used all weapons: preoperative ultrasonography, CT scan, MRI, and intraoperative US. But for example, René Adam from Bruce only used CT scan. But you can see that sensibility of MRI is near 86% in comparison with the rest radiological studies with less sensibility. In this study, Vanderburg and Coles in 2016 showed us the hepatocyte-specific gadocytic acid enhanced MRI imaging is better in this meta-analysis in comparison with constant enhancing multi-slide CT scan. And furthermore, they studied that the modification of the surgical strategy changes from 70 to 35 to up 35%, depending on the study, with you use constant enhancing MRI. In this study, the Tani from Tokyo showed us the greater the metastasis number, the smaller tumor size, and the more circle of oxaliplatin, the more disappearing lesion there will be. In the same study, 111 liver mets in CT scan, disappear liver mets, 44% in MRI and contrast enhanced COU is real disappear liver mets. That is to say, the MRI and intraoperative ultrasonography improve the detection of the disappear liver mets under CT scan. 52.8% were not identified by ultrasonography when MRI did, and 60% were not identified by US, intraoperative US, when MRI did not. In this study by Nales, the English group concluded that the liver-specific MRI before chemotherapy reduced the intrahepatic recurrence and avoids rehepatectomy. The disease-free survival is different with statistical significance. If you use MRI before in initial chemotherapy line, you improve the final result in the follow-up. What do we have to do? There are several possibilities. One of them is, one option could be marking with metal landmark and proposed by M. and D. Alderson. This is maybe useful, but to me, maybe it's not useful in all cases. Perhaps you should not perform missing metastasis surgically when with huge hepatectomy, when in the most cases you don't find or will not find tumor in the resected patient because the tumor cell disappear after chemo. Therefore, maybe no makes sense to mark all lesions. Radiofrequency ablation could be an alternative. In this study, in 2016, other study about the fiducial classmen is very 90% relation were marking, but only 22% have bilobal lesions, 34% there were unique lesions. Instead of mark intraoperatively, it's possible to remove instead to mark with fiducial. And my conclusion is the same. It's useful maybe apply percutaneous radiofrequency instead of a tip. Well, blind ablative procedure. In this study from Israel, Sendel and Coles look forward to getting the navigation system to get visibility of hiding lesion. You can see that consider marking when the risk factor disappear liver mets, local treatment, resection or ablative resection, but when all radiological or intraoperative text is confirmed disappear, segment blind hepatectomy. How? To support the navigation system, the augmented reality. Augmented reality has recently been introduced into surgical file. I know the Professor Lang is talking about this, thereby allowing for the development of 3D virtual model of patient anatomy. When the 3D model is superimposed onto real time patient imaging, we can observe deeper structure and maybe localize the hiding lesions, but it's more expensive. In this video from Strasbourg, you can see the surgeon is look for multiple small lesion and localize one per one lesion with superimposed imaging. They try to look for one of them because they didn't find it. This is lesion, this lesion, this metastasis, and one to one. This is one. This is what? Okay, is localized, and they look for this because they in intraoperative field didn't find it. Therefore, after the combination hologram and ultrasonography, look for the addition of the multiple device and look for and concentrate the possible rarefaction of the area close to this basal. If this is possible, remove it. But I think it's not all hospitals is possible to get this device or this armamentarium. The other and the last approach could be therapeutic abstention. You know perfectly, one of the first to defend therapeutic abstention was Dominique Elias. Remember that he already used contrast-enhanced MRI in all patients in 24. 63% of disappeared lesion after chemotherapy following with high quality radiological check showed no recurrence. So with no recurrence. That is to say, the Dominic Elias was very safety to left the missing metastasis seat. In the next work, in the next article about this, the same group, 69 lesion, the Elias decided that the overall survival rate is comparable with patient removed all seeds of the disappeared liver metastasis. In this study in 2010 from Gelder, the recurrence in the hepatic recurrency is worse in disappeared liver mets, high recurrency in comparison with all original seed treated, but the overall survival rate is similar, maybe because the patient could be, if relapsed, could be rescued or reoperated on. The same conclusion, Gore and Al-Sosuri 2011. The recurrence C is higher in the group, the disappeared liver mets left unresected, but the overall survival rate is the same in two groups. In this article from Bishop, from the group, the team of the public, and to 2013 is the similar graphic. The recurrence is worse in the disappeared liver mets left in situ, but the overall survival rate is similar, no statistical significance. But they recommend us liver resection should be included all original seed disease if it's possible. To brief, is all maybe that owing to 2015, there are no different statistical significance in recurrence-free survival between the surgery or observation. The rest group concluded the same. The overall survival rate, no difference between surgery or resect all shade versus observation, close observation, but the recurrence-free survival is different with this statistically significance. Tani from Tokyo again so it is that only 71% of disappeared liver mets left in situ with MRI negative and ultrasonography constant enhanced negative is only the recurrency 70%. It's worthy to left no remove the specimen to if the surgery change to complex procedure. This is maybe our algorithm: disappear lesion in CT scan, MRI, undetectable pale patient ultrasonography. In my operative theater room, I don't have the possibility to use contrast enhanced ultrasonography, but with this undetectable, we have to careful follow up. Also here to open the door to the same approach, to do the same approach is if not identified or if the surgery is not clearly, because it's possible to remove no correct segment. In this study in 2015, Marco model analyzed Spolverato that its cost of effectiveness, the 6-month systematic chemotherapy in patients with less 60 years with multiple predictor of complete pathological response. Its cost effectiveness in this model that recommended us in selected patient only the follow-up. In here, again, Lucidi group showed us the sustained clinical response increase in all age year, until 82% is the absence of local recurrence in the initial set. And propose that maybe this is the graph. If you have the data of the TANI from Tokyo, is the current data 70%. In around the years, 70% the rates of recurrence when the patient is evaluated with good radiological tests, MRI and contrast enhanced ultrasonography. This global evolution led to change the therapeutic algorithm in some groups. Furthermore, the curative effect of the chemotherapy it's possible to change the unresectable instead of to avoid with your oncology, to avoid the liver, disappear liver mets, it changed the paradigm. Is to try to get more disappear liver mets to get unresectable, the unresectable case to resectable case. That is to say, the first line intensive chemotherapy, if you get a lot of disappear mets, only resection the remnant visible liver mets and left the rest. Is similar to a pseudo chemo pseudo alphs. That is to say, you look for with intensive chemotherapy to convert the patient in unresectable to resectable with you try to disappear lesion. It's the same concept, maybe an R1 vascular resection. In summary, the definition, the complete pathological response is defining after chemo in CT scan file. The frequency is to 5 to 25%, from 5 to 25% colorectal liver mets. MRI and ultrasonography with contrast enhanced is the best check studies to detect disappear liver mets. Resection and observation is a balance. Resection should be performed when with the patient without favorable predictive factors, and observation is possible in selected patients with favorable predictive factor of complete pathological response, less 60 years old, lower CA or normalization, oxaliplatin chemotherapy lines, and small lesions. The overall survival rate, no difference between two approaches, but disease-free survival is better when all resections or all resected sits in disappear liver mets. Therefore, therapeutic abstention, perhaps the more logical approach nowadays is therapeutic abstention in case with predictor factors of complete pathological response and with careful follow-up with MRI. We will avoid performing unnecessary surgery in around and about 90% of cases. It's possible to use the disappear liver mets to get resectability in worse cases. The 3D techniques coming may help surgeons in the resection in the future, but at the moment it's very expensive for all worlds. But it's very useful to help us to avoid recurrency or close recurrency when I left not resected disappear liver mets zone. Acknowledgement, I would like to thank Fernando Rotellar and the security team for your attention. I welcome to Bilbao in September. Thank you so much.
Thank you very much, Professor Sarablo. It was a wonderful presentation and a very authoritative review of the literature with your personal views on how to proceed in particular patients. Now we will hear from Professor Lang.
Hello, can you hear me? Can you see my slides?
Would you please share your screen?
Okay. You see it?
Yes.
Yes.
You see my slides?
We see your screen.
The left or right? I have two.
We see neu bei der Heimarbeit.
Then
Hier finden Sie einige Tipps.
See the wrong one. Okay. And now?
We see you.
Oh. That's a problem again. Don't see my slides?
Not yet, but we will. Maybe I can pop one question to Professor Sarablo in the meantime.
Okay.
Professor Serablo, how do you change your patient consent form in such patients? Probably you have a standard form for metastasis resection. Do you include any particular statements by the patient? Do you include any specific statements about the disappearing metastasis?
No, because the general consent form normally advise him or her the possibility in operating room field, we don't find the lesion, and in balance the risk benefit. If you have 3 disappearing liver mets in 7, 2, and 3, it's easy to you and to remove 7, 2, and 3 if the rest of surgery is only 7, 6. But if the disappearing liver mets is down median hepatic vein in deep the 7, 8, you don't find the implied maybe resect mesh hepatectomy to look for that, or the blind lesion without landmarks, is possible to convert the surgery in complex surgery, or with increase a lot the risks, and sometimes you have to left the disappearing liver mets without remove. But the patient normally is in the consent form, we inform the all possibility. Is the same, for example, ALPS. In very multi-lobar cases, you offer the 1 stage, but sometimes during surgery, it's possible to convert ALPS or to convert to a stage hepatectomy. The patient is informed that this possibility is open during operative theater room. Okay.
Thank you very much. And now we can see Professor Lang's screen. Professor Lang, please. Professor Lang, can you hear me?
Yes, can you hear me?
Yes, we are ready to listen to you. We can see your slides perfectly now.
You can see me, can hear me, and now it's okay?
Yes, it's perfect.
Okay, then I'm sorry for the trouble, but finally it works. And thank you very much for the invitation. It's a great honor and a pleasure for me to give this talk today. And I want to thank you personally, but also my friends from Turkey, from the Turkish HPB chapter, for the long-standing friendship starting several years ago, and for the great support you gave me in 2017 in Mainz. And I had several opportunities to come to Turkey, to Antalya, to Istanbul. So it's really a pleasure for me, and I hope the COVID pandemic will stop soon and we will meet again soon, maybe in Mainz, maybe in Turkey. So thank you very much for the invitation, and thank you very much for the topic. I'm talking about vanished or diminished liver metastasis, and you already mentioned it when you introduced us, that probably there is a definition missing. What is vanished, what is diminished? And I will try to give some answers about the definition, how often we have a complete pathological response, what about the prognosis in vanished colorectal liver metastasis, and finally, what is our treatment strategy, how to detect the metastasis, and how to resect, and probably how much to resect. So the first who talked about vanished colorectal liver metastasis was Dominic Elias. Alejandro already showed the slides, but the first who brought it more or less in our mentioning was Benoit. It was the EO-RTC study from Nodlin Che. And in this study, he had plenty of patients with diminished colorectal liver metastasis or disappeared. In total, there were 66 colorectal liver metastases in 38 patients that had disappeared. And they did operation in all of them. And in 20 cases, they found the metastasis in the operating room in the liver. And in 46 cases, they were not visible. They resected the areas where the metastasis had been, and they found vital tumor cells in 12 out of 15 cases. And they left 31 areas in situ. And after 1 year, there was recurrence in 23 out of 31 areas. So in total, 55 of 66, I'm sorry for the mistake, of the metastases had never been gone or recurred within 1 year. So there was cure only in less than 20%. This was the first major report on vanished metastases. And a few years later, several reports occurred. Alejandro has shown the slides already. You see the complete remission rate in those patients where we had diminished liver metastasis, very high, but it varied from 17% in Benoit series till almost 70% in Tanaka series. This certainly was because of different imaging modalities. Tanaka used MRI, Benoit did not. Our used hepatic arterial infusion therapy. But what was common in all the series was that the survival of patients was very good, almost 70% after 5 years, even if the tumors recurred. And we have already seen this study from Van Vletter, published 10 years ago in CHOCS. He showed that the survival is the same if you leave the metastasis or if you resect. But of course, the intrahepatic recurrence-free survival is much better if you do resection. So, but these data are 10 years old. Now coming to some newer data, and what is the risk for developing a diminished liver metastasis? Of course, if we have a small metastasis, if we do many cycles of chemotherapy, if we have plenty of metastasis, then usually you have also some small. And in total, about 1/4 of patients receiving chemotherapy develop diminished liver metastasis. And maybe this is even bigger in series where you give a lot of chemotherapy or where you use only poor imaging modalities. And the number of diminished liver metastasis is higher if you use a platinum-based chemotherapy, because the liver becomes fatty, then it's more difficult to detect in CT. The same data by multi-center analysis from the Timpoli group, 15 studies included, almost 500 patients with more than 1,500 diminished liver metastasis. Of course, those metastases that had been very small prior to chemotherapy were at risk to diminish totally. Now looking a little bit more, what imaging modality do we need in diminished liver metastasis? This is data from paper from Barimani, published 1 year ago. They had data from 15 studies all over the world with almost 3,000 patients and a total of almost 5,000 colorectal metastases. And out of these 5,000, 1,561 metastases diminished after chemotherapy. And in some series, it was up to almost 50% of patients that showed diminished liver metastasis after chemotherapy. Now, what we are talking about, they gave us some definitions. A remaining liver metastasis is a metastasis that never disappeared under chemotherapy. A diminished liver metastasis, DLM, is a metastasis that was visible in CT scan, but no more visible after chemotherapy in CT scan. A residual colorectal metastasis, this is a diminished metastasis, but this metastasis can be visible in other imaging modalities than CT, maybe in MRI. Complete pathological response, we have no more viable cancer cells. In resected diminished liver metastasis in pathological analysis. Complete clinical response, if we have no recurrence of a diminished liver metastasis that was left in situ during follow-up. And the complete response is if we have complete pathological response or complete clinical response. These are definitions given by Barimani, and now we know a little bit what we refer to. So, what did they find when they analyzed the literature? Almost everybody, with the exception of Kim, used CT scan for detection of liver metastasis before chemotherapy. After chemotherapy, many use also MRI because it's better to visualize metastasis in MRI. And intraoperatively, everybody uses intraoperative ultrasound and some also with contrast enhanced ultrasound. And what did they find? They found all remaining colorectal metastases identified by CT scan were also detected by MRI and intraoperative ultrasound. So MRI and intraoperative ultrasound got all the metastases that were seen on CT scan. But almost 40% of metastases that were diminished in CT scan could be detected either by MRI or by intraoperative ultrasound. So these modalities seem to be much better in detecting metastases. And almost 20% of the metastases could be detected either by MRI or contrast-enhanced ultrasound only. So the diagnostic workup in diminished liver metastases should include CT scan, MRI, and intraoperative ultrasound, and if available, of course, contrast-enhanced intraoperative ultrasound. And what did they find regarding diminished liver metastases and complete response? If the metastasis remained undetectable in MRI and contrast-enhanced ultrasound, so if there was no metastasis either in CT scan, MRI, and contrast-enhanced ultrasound, then the chance for a complete remission was almost 90%. It was in median 98%. So if it was visible, wasn't visible, then it was almost definitely gone. And of course, they found that patients who had resected diminished liver metastasis had a better disease-free survival, but no longer overall survival. This were the data from Barry Yami. And now coming to our clinical scenarios. These are the scenarios we have in colorectal metastasis. The primary resectable metastasis, the questionable resectable because of close proximity to large vessels, because of large size of metastasis, because of multiple metastases, and probably those we will never resect on the right side. Where do we give chemotherapy and where do we probably do resection? In the oncological questionable, where we have multiple metastases, maybe initially resectable or borderline resectable, and of course in the primary resectable metastasis. I don't want to discuss whether it's necessary to give chemotherapy, but we often see patients who had initially resectable metastasis, but who received neoadjuvant chemotherapy. So we have to deal with these situations. So the first question is when to resect after chemotherapy. If the tumor was initially irresectable, like in this picture here, this was not resectable, not at all. We did a downsizing, and of course we resected as early as it was possible. In the primary resectability, this tumor, of course, was resectable initially, and it was downsized. So here we have no special answer because it was initially resectable. But in the irresectable, we have to resect as early as possible. And how much do we need to resect? In the left side, of course, it's not possible to resect all the areas where the tumor had been because it was primarily irresectable. But we have to stick close to the metastasis. On the right side, we could resect the initial area. The same we do in rectal surgery or in esophageal cancer surgery. Whenever we do neoadjuvant chemotherapy or radiochemotherapy in esophageal resection or colorectal resection, the resection area is the same as without neoadjuvant chemotherapy. But in liver metastasis, it could be different. Do we need to resect only this small area, or do we need to resect the entire area where the tumor had been? There is some data from literature showing after chemotherapy, micrometastases around the tumor are only in an area of about 1 to 2 millimeters, whereas if you have no neoadjuvant chemotherapy, then you have satellites and micrometastases within the area of about 1 centimeter around the metastasis. So after neoadjuvant chemotherapy, we need only a very small safety margin, about only 1 to 2 millimeters. And this is also supported by data how a metastasis is shrinking. It's shrinking from the periphery to the central part, not concentric, but almost concentric. So there's only little viable tumor next to what can be seen of the metastasis. So coming back to the example, we don't need to excise all of this area. It's enough to excise only this area after chemotherapy, and that is what we did. You see here the specimen, you see here the vena cava and the right hepatic vein, and there was no vascular invasion. So we can stick very closely to the metastasis after neoadjuvant chemotherapy. This also we need to know when we have vanished metastasis. So what to do? To resect or not to resect, or just to observe and give chemotherapy? We had already seen this data, and there's only one study in literature that is from Van Vletter, who says that the overall survival is the same, but the disease-free survival is less if we leave the metastasis in situ. All other CAs have good survival data, but they do not compare disease-free survival in resected and non-resected metastasis. So the first question is how to find a diminished liver metastasis at operation. Alejandro already showed the data from Zelinsky, tagging the metastasis by interventional radiology, and Karl Oldhafer, my friend from Hanover, did a navigated liver resection almost 10 years ago. But to be honest, they made a huge hole in the liver just to remove a very tiny metastasis. These were the first attempts. Of course, what do we need to do? At operation, we need to mobilize the liver fully. We need to palpation and intraoperative ultrasound. Later, Alejandro Ferrero again supported the use of intraoperative ultrasound, and of course, the use of intraoperative ultrasound with contrast medium is favorable. Our own department, and we published this in 2016, we used computer-assisted 3D navigation in open surgery and in laparoscopic liver surgery. And I will show you examples. And we have already seen by Alejandro the augmented reality by the Strasbourg group. Now coming to our data. When we do intraoperative navigation, what do? We have to synchronize our 3D model with our intraoperative ultrasound. You see here our 3D model, intraoperative ultrasound, and we synchronizes. And then we have to synchronize our ultrasound with our ultrasound dissector. This is our equipment in the operating room. You see here the 3D reconstruction of the liver with the metastasis. Here, 2 vanished metastases after chemotherapy. This is the CT scan after chemotherapy. And now I want to show you a video how we resected this by navigation. I hope it works. You see the scan. This is the liver with the 2 metastases. Now we do intraoperative ultrasound. The metastases were no more visible in CT scan. This is the CT scan before chemotherapy, but it's visible in ultrasound. So in this case, we did not need a navigation. Then we navigated the CUSA. We could see the tip of the CUSA on the screen. And finally, we removed the specimen. So this was only proof of principle. Of course, we could have resected this metastasis without navigation. The same we did in the metastasis, small metastasis close or next to the gallbladder. You see it here. After chemotherapy, it was gone. This was initially on the right side, the initial CT with this tiny metastasis. And we did a navigated laparoscopic resection. You see it here. The same use of instruments, but now we have laparoscopic ultrasound and we did a laparoscopic navigation. Again, proof of principle. We still follow this technique, but not for detecting of vanished colorectal metastasis, but just for improvement of our resection. And the augmented reality, Alejandro already showed. Here you see metastasis in location number 16. Prior to chemotherapy, after chemotherapy, it's gone. This is the equipment in the operating room. And this Alejandro has already shown. The colleagues from Strasbourg did this in 3 cases with 4 metastases. They could resect all 4 metastases, but I don't think there has been a next follow-up of this technique. It's very sophisticated, and probably I think we don't need it to find vanished colorectal metastasis. The use of tagging, and Alejandro has already shown this paper from Passot. They had 32 patients with 41 colorectal metastases, small metastases, most of them deeply in the liver, and 19 out of the 41 disappeared after chemotherapy. You see it here, metastasis, and here tagged metastasis, again here, here, and here. And what did they find? They could resect 31 out of the 41 tagged metastases. In 9, they had a complete pathological remission. 10 areas were ablated. After about 2 years of follow-up, they had no local recurrence, neither where they had resected nor where they had ablated, but they had a 50% recurrence at other sites. So the diminished metastases probably are not the problem, but metastases at other sites. And one of the best paper I found is from UBA in HPB 2080. They have a very, very good follow-up and a very good program. They had over 6 years, 184 patients with colorectal metastasis. In 59 patients, so about 1/3 of patients, they had a total of 275 diminished liver metastases on CT criteria. So in CT scan after chemotherapy, 275 metastases were gone. All patients received MRI prior to operation. All patients underwent operations, and all patients received intraoperatively contrast-enhanced ultrasound. You see here on the right side, as they followed up, metastasis on this CT scan seen before chemotherapy, yes. After chemotherapy, yes. No in number 5 and number 6. Number 5 is here, was seen on MRI, but it was not seen, number 6 was not seen on MRI here. This is missing on MRI, but this could be seen in intraoperative ultrasound. So this was their schedule. And now looking at the results. In total, they had 275 diminished liver metastases in CT scan. And we have to look from below coming up. Preoperatively, they did MRI and found 71 out of the 275 metastases. So about 1/4 of metastases could be seen in MRI before operation. All these 71 were resected, and a little bit more than 90% of these metastases still contained viable tumor. So those that could be detected by MRI were still almost all viable tumor. Intraoperatively, they could detect another 94 metastases by contrast-enhanced ultrasound. And they resected all these. And here in 66%, still viable tumor was present. So only one third of metastasis that was seen on ultrasound was completely pathological response. And finally, they had 110 metastases which they did not find at MRI before operation, and which they did not find with intraoperative contrast-enhanced ultrasound at operation. These were 110 metastases. They resected 68 of them by blind resection and left 41 in situ because they were deeply located or they didn't know exactly where to resect. And here, the percentage of viable tumor was low, only 8% viable tumor, but 92% had no viable tumor or did not recur. So what we can say, if we can't detect a metastasis on MRI and not on intraoperative ultrasound, in particular not on contrast-enhanced ultrasound, then the chance that it is a complete pathological response or complete clinical response is very high. It's almost 90%. So what can we conclude? About 50% of metastases that can't be seen on CT scan can be detected either by MRI or ultrasound intraoperatively. In about 70% of metastases that can be detected by MRI or ultrasound, there's still viable tumor, so we need to resect these metastases. But if we can't find a metastasis by MRI or intraoperative ultrasound, then the risk of viable tumor is very low, and we can almost leave this, or probably leave this. So let's take together. There was a survey published last year with more than 200 surgeons, and they used preoperatively CT scan or MRI for detection of metastasis. And when they went to the operation room and didn't find metastasis, what did they do? Half of them did not do a blind resection. 1/3 did a blind resection if the metastasis was superficial. 13% did a blind resection regardless of the depth of metastasis, and even very deeply located diminished metastases were tried to be resected. And 7% did ablation of the diminished metastasis. But more than 80% believed that just surveillance is also effective. Now coming to our own strategy in Mainz, what do we do? If we have primary resectable metastases and they are located superficially, like here or here or here, usually we don't want to have neoadjuvant chemotherapy, but sometimes we get the patient referred from somewhere else and they had neoadjuvant chemotherapy. If we have these situations, one solitary resectable metastasis, superficial location, then we would go for resection. And also if we have 3 in superficial location, then we would go for resection. So resection if there were primary resectable metastases. If we have primary resectable metastasis but deep location, then things are a little bit different. If they are located deeply in the liver, we don't know whether we should do a resection like this. So this is a very individual decision. Wait and see is also accepted, but depending on what the patient prefers, we sometimes also go for resection, but mostly we go for wait and see strategy. And if we have primary irresectable metastasis, like here, multiple metastases, probably we could resect, but in these cases we do chemotherapy prior to operation, and here again. If we have from here to here, so downsizing and shrinking with diminished metastasis, certainly we would go for operation and resect this. We also would do blind resection of these areas if they were superficially located, but we would not do an additional deeply resection for one metastasis deep in the liver parenchyma. So again, individual, I'm sorry for the mistake, decision. We would resect all visible metastases, maybe resect blindly, atypically, if they are superficially, if they are easy to resect, but we would leave a deeply located metastasis. And here in this example, we have huge tumor mass on the right side and multiple small on the left. And after chemotherapy, this still huge tumor on the right side, but no on the left. We would go for right resection, but probably we would leave all the metastases on the left side. If we could not find them at operation, we would not do blind resections here on this side, just resect the visible metastasis and leave the diminished metastasis in this situation, because it was primary irresectable and the risk for recurrence is very high, extremely high, even if we could find all these areas of diminished metastasis. So let me conclude. We have about 25% of diminished liver metastasis, and sometimes depending on the quality of imaging and on the intensity of chemotherapy and target therapy, it may even be up to 50%. Of course, there's a higher risk for development of diminished liver metastasis if the initial metastasis was small, if we have multifocal metastasis, or if we use oxaliplatin-based chemotherapy. The preoperative workup should include CT scan and MRI. We can tag metastasis and imaging with fiducial placement of some clips may help to guide intraoperatively and find the metastasis, but I'm not sure whether we need this. At operation, we should do a complete exploration with palpation of the liver, with ultrasound of the liver, and if possible, contrast-enhanced intraoperative ultrasound, and resection of all diminished liver metastases that we know is associated with a better disease-free survival, but not a better overall survival. So, resection of all sites of diminished liver metastasis is advocated, and this is what we say, but it has to fit into the oncological concept, as I showed you in our examples. So finally, our approach is, if we have a potentially curative situation, a true neoadjuvant setting, and we have downsizing of metastasis and diminished metastasis, then we go for resection. Wait and see is only accepted if the site is unfavorable. Of course, we try to avoid to get a diminished liver metastasis. We don't want to have neoadjuvant chemotherapy in those metastases, but sometimes we have because patients are referred from somewhere else. But it is a if it is a potentially curative situation, then we prefer resection. In initially irresectable setting, if we have downsizing of plenty metastasis, then we prefer the wait and see strategy. I thank you very much for your attention, and thank you very much again for inviting me to this great meeting. Thank you.
Professor Lang, thank you for your very informative and enlightening presentation. Now the topic is open for discussion. I will watch the chat channel to see whether there are any questions. And also questions may be posed through the YouTube channel. They will be communicated to me by the host. I had asked a question to Professor Sarablo. I will ask the same question to you. Do you change your patient consent form in any way when you have a patient with vanishing, diminishing liver metastasis, or do you have a standard consent form that includes all possibilities or potentially all possibilities, of course?
Yes, of course. We include all possibilities, resection, non-resection, ablation, but we hardly do ablation at operation. We do it after operation by CT-guided ablation, but we don't change, yes.
Okay. There is one question from Dr. Silvio Nadelin.
My friend.
The question is resection the only chance for DLM? What about ablation, for example, RFA of deep metastasis? You actually mentioned this, but I think Dr. Nadelin requests you to elaborate. We can start with Professor Sarablo.
The ablation I'm sorry, can you repeat?
For example, if I understand the question correctly, for example, you have a deeply situated diminished metastasis. Would you use ablation rather than an aggressive resection that may cause bleeding, etc.?
Depending on, for example, if the feeding is into operative theater room, maybe go ahead with the surgery, because sometimes the recurrency, depending on the site of the metastasis, but if previously is deep position, sometimes it's possible percutaneous microwave to treat this lesion and after go to the easier surgery in the next step.
Do you prefer microwave over RFA?
The prefer is the radiology preparation, because it's radiology who performs this. But normally the microwave has very safety area around the basals or biliary ducts in comparison with radiofrequency. Also, as a surgeon, normally you can realize the recurrence rate in the seat is more frequent if more frequent than R1 resection, for example, in our experience.
Dr. Lang, may we ask the same question to you?
Yes. So if we have a potentially curative situation and superficially located metastasis, then we prefer resection. But if it's a deeply located metastasis, for instance, one deeply in the right lobe, then we prefer ablation. So ablation is, of course, an alternative.
Okay, there is one question on imaging. I will expand it a little bit more. Both of you have mentioned the superiority or radiological superiority of an MRI with hepatocyte-specific agent. But in the examples you have shown, we have seen CTs. Do you prefer to use both? Do you think they are complementary? And what is the role of the PET-CT in the evaluation of these patients? Professor Sarablo.
For me and in my hospital, the PET normally is when the extrahepatic disease, ganglion, the pulmonary, peritoneum, pelvis, because to check when you suspect the extrahepatic disease, not only with the metastatic diseases only in the liver, no use PET scan.
Okay.
So
except in another, I am talking about the colorectal liver mets, no other tumors. Huh?
Professor Lang, please.
We rarely do PET-CT scan, and if we do it to detect metastasis in the chest or lymph node metastasis, regarding the question CT scan or MRI, our first option is always CT scan. But if we have several metastases and after chemotherapy with downsizing of metastasis and vanishing metastasis, then we always do also MRI.
Oh, okay.
Both. Then we do both.
Another question from Dr. Nadelin. Who is performing the contrast enhanced EO ultrasound intraoperative at your center, surgeon or the radiologist? What about the learning curve? Professor Lang, I think.
Silvio, we don't do it regularly, but if it's done, we do it on our own. So the surgeon is doing it, but we don't do it in any case. So I have not so much experience with it. We did it, but we don't have the same results as others have. To my knowledge, the only one who does it on regular basis in Germany is Hans-Jürgen Schlitt. They do it and they have very good experience with it.
Do you know the name of the contrast agent that they use? Is it commercially available in Germany, or
they
receive it on a complimentary basis?
I have to look it up. I will send you an email.
But okay. I think the contract is SonoView. No, it's maybe.
Yes, I think so.
SonoView. It's a path-specific contrast too, but it was different distribution with gadocetic acid enhancement. But in my case, I don't have possibility because my ultrasonography device is not possible to use constant enhances. And sometimes in concrete case, when detected in MRI the lesion and it's impossible to me to detect into operative theater room, I look for my radiology and move his device into operative theater room to perform the exploration. But I don't have experience. It's performed by the radiology.
Oh, okay.
But if my director managers buy me this device, I will learn how to do that.
Okay. Do you have anything to add? And or can we proceed to the next question?
Well, I would like to maybe, because you can see it's possible to superimpose or overlap the conclusion of Hauk and my conclusion. It's the same conclusion. If maybe Professor Osset Osden is the similar to you. But for example, the slide from Professor Lang, one only lesion here is when I suppose that no chemotherapy is directly to surgery because it's only disease, because if possible to have, the problem is in one lesion or two lesions, as a Pashot study, is the situation. How is the disease? There is a primary tumor in situ. There are multiple liver metastases. There are a suspicion of the peritoneal carcinomatosis. Therefore, the patient go to the chemotherapy instead of to remove the lesion of the liver. It is more possible to change to disappear liver mets during follow-up. Yeah. It's only this because it's very easy to put in an algorithm, but the algorithm sometimes with multiple variations. For this reason, I think it's individualized the decision making of the patient, as recommended Professor Lang.
Okay. One other question. There's a question about blind ablation of previous metastatic sites rather than resection. I think one problem with this ablation thing, especially with RFA, is that you leave a suspicious site which is recurrently visible on imaging. So maybe it's difficult to evaluate if you have, for example, 3 ablated sites. So is, for example, microwave advantageous in this respect, or is it maybe better to leave them alone so that you can evaluate more easily with MRI? Professor Lang?
Difficult question. To my mind, if you have multiple metastases and you have give chemotherapy and then you have diminished metastasis, I think you can leave them. You don't need to resect or to ablate because the patient will have recurrence anyway. Maybe not at that site where the metastasis has been, and this was clearly shown by the data from the Nick Vote group by Passot. They have metastasis at other sites. So I think it's only necessary to remove what you can see and feel during operation, and everything else you can leave, unless it's a solitary metastasis and you have the chance to cure. Then you should either resect or, if it's deeply located, ablate. But if there are 5 diminished metastases out of 10 metastases, then the patient will have recurrence anyway. And I would not do a huge operation and several ablations to treat them.
Any comments, Professor Serablo? I am convinced that some patients who suffer or get or have disappear liver mets he is from irresectable situation, and a good response with a lot of liver mets with disappear in MRI, for example, a CT scan. It's possible this patient, if you analyze the tumor biology, will be the best candidate to go to the transplant. Maybe the complete pathological response or clinical sustained response could indicate us this is the best candidate to go to the transplant. It's possible because we have to work with the small data because there are 150 mutation wave only the adenocarcinoma, normal 150 way of mutation. Therefore, maybe an indirect market is possible to complete pathological response. I would like to know and explain patient from Oslo, from Silvio, to remove the liver and put the transplant in the specimen, how many lesion is complete pathological response or have complete pathological response in comparison with not.
But Alejandro, those patients having complete response or diminished metastasis anyway have a good prognosis.
Have good prognosis?
Yes. The prognosis is 60 to 80%, 5 years anyway. So why transplant them?
The recurrence rate in transplant at the moment is almost 100%. Even for example, in our procedure, the cure words is usually used for us. I am out surgeon, and in real data, I review 8 years after. For example, you look for the patient death by colorectal mets. Yeah. And it is it's a complex question to me.
But maybe the role of transplantation is evolving, but probably there will be swings of opinion, and and we will hear maybe in future meetings. There is one other question. Do you consider the histopathological features of the primary tumor in your approach to the disappearing colorectal metastasis? Professor Lang?
This is a very difficult question because we did very careful analysis of the molecular analysis of the primary tumors and liver metastases. And if you have mutations in the RAS pathway or the SMET pathway, then of course you have a worse outcome if you have patients with colorectal metastases. But so far we don't look at the primary tumor. Do we have any molecular biological changes of the primary tumor? And in case if we had a BRAF mutation or a SMAT mutation, then we would say we do ablation of a diminished metastasis. No, we are not so advanced to say yes or no. So far we don't look.
Professor Sarablo?
Well, I have the same opinion, Professor Lang, because it's very difficult. And furthermore, if you operated the primary metachronic lesions, if you have adjuvant chemotherapy, it's possible to the behavior of the liver mets change. It's maybe the resistant chemo cells, tumoral cells, and the mutation advance is different behavior with the primary tumor in metachronic disease. And I think it's very, now we are not talking about right colon, left colon and rectum. The behavior of the primary tumor and their metastasis is different, because the right colon, everybody worry about the multimetastatic liver in right colon cancer, because the evolution is that is worse in comparison with left colon. I think molecular biology has to say something about that.
But the molecular profiling is not so advanced that we can make a decision based on profiling at the moment.
At the moment, no, but in the future.
Okay. Another aspect, sometimes it's rare, but it happens. We have patients with discordant lesions. For example, if in a patient with multiple lesions, sometimes 1 or 2 disappears, 1 or 2 regresses, and then maybe you have 1 or 2 progressive lesions. This is rare, but it happens. Do you change your strategy in any way? Professor Lang first, please.
So if we have this situation, then certainly we go for a resection, remove these lesions, certainly.
Okay, Professor.
I agree, the same, because it's a high suspects the behavior is worse. Remove.
Okay.
Good
this
question.
Shows that there need not be the concordance between the primary tumor and metastasis. And sometimes metastases are different. One metastasis has a mutation, the other has not. So this is a very interesting field, and we have to study a lot to understand this. But if we have some metastasis diminishing and some growing, we go for a resection for the growing. Okay.
And we don't want to trespass to the field of maybe colorectal surgery, but one question that comes to mind is, sometimes the primary tumor disappears completely, and so you have regressed liver metastasis. how do you perform the colorectal resection? How do you, or if the colorectal surgeons do it in your institution, how do you collaborate with them? If the primary tumor practically disappears and you have some residual liver mets that require surgical attention. Professor Lang, please.
So we do colorectal surgery in my unit, so we don't have to ask anybody else. And we remove the liver metastasis and also do resection of the primary
Site.
Yes.
Yes. Me too.
Yeah. The only exception is if it's a very deeply located tumor in the rectum.
Mm-hmm. Mm-hmm.
Then probably we wait and watch, because deep anterior rectal resection has a lot of, it's not so easy for a patient, but usually we go for a resection.
Okay.
But in my case is when the rectal is very lower, nearest to the anal canal.
Yes, the lower it is,
the lower
we are to do a resection if it is completely gone. We know the gamma data, and I think we have 20 to 25% of complete remissions, and we can probably do just a TAM just to excise the area where the tumor had been, to avoid that the patient gets an anospreader or something like this. But usually if the tumor is located a little bit higher in the upper part of the rectum or in the colon, we go for a resection also of the primary tumor.
Yeah.
Okay. This question may seem naive, but have you had cases in whom you detected the metastasis by palpation only? I mean, you knew it was there, it was invisible on all forms of imaging, but you palpated something and resected and found this or that.
Yes.
If you palpate, yes. If you palpation, remove.
Okay.
Normally, because the liver parenchyma, the problem is not only the metastasis, the quality of the liver parenchyma around the lesion. If you palpation the lesion and localize, remove.
Okay. And let's talk a little bit about post-resection recurrence. For example, let's say you have a patient with multiple lesions, and then some of them vanish, some of them diminish, and you perform a surgical resection according to the strategy you have outlined. Maybe 3-4 months later, you do the first imaging. Is that the time where you do it? And what do you do if you have an early or late recurrence in a patient with previously multiple lesions? And how do you define early recurrence or late recurrence in your clinical practice? Professor Lang, please.
So yes, usually we do first CT scan after 3 months. Mm-hmm. In case we find one recurrence, we talk again about chemotherapy. Probably we talk about ablation, but we will not go for repeated resection after 3 months. Mm-hmm. So if we find a solitary metastasis after maybe 9 months or 1 year, then of course we talk again about repeated resection, but not after 3 months.
Okay. Professor Serablo?
My opinion is the same, but sometimes I oncology usually CT scan and 1 month after surgery, but it's very, very, I suppose that is a check us instead of to evaluate the oncological approach. But 3 months only, sometimes you, in this context, the vanishing liver mets maybe is no early recurrence. Maybe you have left the metastasis in the first operation. It's a very, very few small lesion grow during the follow-up in these 3 months. Therefore, if 6 months, 3 months, the patient has a recurrence, maybe I add adjuvant chemotherapy and wait to reevaluate pre-operation again.
One other question, of course, it all comes down to imaging. Do you feel that patients with colorectal cancer need a baseline liver MRI to serve as a basis for future imaging? Because many cases of colorectal cancer undergo surgery with CT imaging only, and that CT imaging, as we know, misses some of the metastasis. Sometimes, for example, people are referred for early liver mets, but when you check the CT very carefully, maybe there's a hazy image of that new metastasis in the original imaging. Maybe MRI would have been more useful, but of course, performing MRI on every colorectal cancer patient would be costly and maybe even cumbersome. What is your opinion? Professor Lang and then Professor Sarablo, please.
That's difficult. It's a question of expenses, and we usually rely on the CT scan, and only if we have multiple metastases, then we do initially also MRI, but not in every patient, no.
Okay. Professor Sarablo?
I think that in selected patients, the MRI should be performed, because it's no, if now, for example, the study presented on a slide from Professor Lan and I is 2002, 2004, 2016, 2018, maybe 2020, but the CT scan and CT scan has been improving around the years with more smaller slides. 1 centimeter, 5 millimeters, 1 millimeters, less 1 millimeters. That is to say, in neoadjuvant chemotherapy, the patient is going to neoadjuvant without resection previously. The MRI is maybe recommended for this case, but in all patients, not. This enhanced CT is enough.
One last question from Dr. Sami Ramzi. What about regional chemotherapy via the gastroduodenal artery port? Professor Lang and then Professor Sarah.
Lang is German and I'm Spanish, no French.
Sami is from Egypt, from Cairo. Is my good old friend. He was in Hanover, so I know him for 25 years. And when he was in Hanover, at that time we did regional chemotherapy via a port in the gastroduodenal artery. So it's more than 20 years ago when we did it. Since that time, we did not do it. And I'm not sure somebody does it here in Germany. Dominic Elias did it in France. And Nancy Kemeny at the Sloan Kettering has tremendously good results after intraarterial chemotherapy via the gastroduodenal artery. So
institutional preference.
Absolutely. And it's discussed at every Congress, and nobody can repeat the same data, but the data are great from Nancy Kemeny, but we don't have the experience. And in Germany, I think at the moment it is not done, although the concept is convincing.
Okay. It has been a wonderful webinar, Professor Sarablo and then Professor Lang. I would request your concluding remarks before I finish the meeting. Professor Sarablo.
Thank you so much for this invitation. The Turkish chapter is a magazine. I know perfectly you evolution. Very congratulations for your work. In concerning in the severe liver mets, the conclusion is the last slide from how LAN is individualized the case by case and select the better way for each patients. Thank you so much to secure the team for your invitation for your congress, your webinar.
We have been honored to host you. Thank you for your participation. Professor Lang. Yeah, thank you very much again for the invitation. It was a great webinar. Thank you very much for the friendship of the Turkish HPB chapter and for the many meetings we had together. And again, I hope we will meet again soon, either in Germany or in Turkey. Regarding the topic, it is a very interesting and challenging topic, And it will change in future with improvements of chemotherapy, of target therapy, and improvements of imaging modalities. I think the number of complete pathological responses or of those diminished metastases that are truly vanished will increase tremendously. And I think in future, what is gone on imaging modalities most probably will be gone also pathologically and clinically. So the need to resect blindly will decrease.
We thank again for the two experts and all participants for making this webinar a success. I'm very happy that you shared your time on a Sunday on this important topic. I'm sorry, it will be a Saturday or a weekday in the future. I am sorry for the inconvenience.
Oh, it's fine.
No, it's fine, it's fine.
Looking forward to meeting you in future meetings, hopefully in real life, not on
September 5 September after 15 September 2021. Remember. Bye-bye. Thank you so much.
Have a nice day, everyone. Thank you.
Thank you.